Hi guys, welcome to Dogshala. So in this video, we are going to see about an important manifestation in lungs, that is COPD, that is chronic obstructive pulmonary disease. So let's just dive into the topic now. So what is chronic obstructive pulmonary disease? So it refers to a chronic and irreversible lung diseases which is characterized by persistent airway obstruction leading to increased resistance to airflow. The resistance to airflow is increased. That is, there is decrease in the airflow in the lungs. So it primarily encompasses chronic bronchitis and emphysema. It primarily encompasses chronic bronchitis and emphysema. They often coexist, or one might predominate the other. Okay, so it varies in different individuals. Okay, so let's just see. So what is chronic bronchitis and what is emphysema? So chronic bronchitis is chronic and excessive mucus production within the tracheobronchial airways. Chronic bronchitis leads to chronic and excessive mucus production. The diagnostic criteria for chronic bronchitis is persistent cough with sputum expectoration for at least 3 months per year over 2 consecutive years. Persistent cough with sputum at least 3 months per year for 2 consecutive years. Then we can diagnose it as chronic bronchitis. Then coming to pulmonary emphysema, it involves distension of air spaces located beyond the terminal bronchioles. The air spaces distend, which are present beyond the terminal bronchioles. It is accompanied by destructive changes affecting the alveolar septa. So chronic bronchitis and emphysema both contribute to COPD, but one dominates the other in a clinical presentation of a given individual. This you have to remember. Then coming to the etiology. So emphysema. So first of all, emphysema, the causes of emphysema include chronic alveolar inflammation, any factor which is leading to chronic alveolar inflammation that is contribute to the development of emphysematous lesions, smoking, and some genetic factors. Whereas for chronic bronchitis, the etiology may be bronchial irritants. Bronchial irritants, the irritants such as cigarette smoke, or a prolonged exposure to such irritants may cause chronic bronchitis. And environmental factors in some developing countries, like household smoke, which comes from the kitchen, or burning firewood, is also a major contributing factor for the chronic bronchitis. Okay, then pathological changes and pathophysiology which is involved with emphysema and chronic bronchitis, both we will see. First, let us see about chronic bronchitis pathology and pathophysiology. The pathological changes which are involved in chronic bronchitis include several structural changes. Okay, the structure of the alveoli is involved in chronic bronchitis. They include hypertrophy of mucus glands in both large and small airways. This leads to thickening of air walls and excessive production of mucus, resulting in narrowing of the airway lumen. As you can see in the image here, there is thickening of the airway walls. These walls are thickened. This is healthy one and this is a diseased one, right? These walls are thickened, you can see. And excessive production, and the lumen size here, the lumen is in healthy one, the lumen is broad, but here the lumen is very narrow. Okay, so these are the pathological changes which we see. Then coming to the alveolar involvement, in chronic bronchitis, alveoli are typically spared and there is no significant loss of blood vessels, and lung perfusion remains relatively normal, but ventilation is significantly reduced. Perforation is normal, but ventilation is significantly reduced. Since there is decrease in the ventilation, there is ventilation perfusion mismatch. in combination of excessive mucus production, there is ventilation perfusion mismatch resembling arteriovenous shunting. Patient often experiences hypoxemia, which can manifest as cyanosis. Then acidosis, prolonged hypoxemia. Prolonged hypoxemia is decreased oxygen content to the tissues. So prolonged hypoxemia leads to acidosis and can contribute in development of pulmonary hypertension and right heart failure over the long term. Okay. Then emphysema. The pathological changes that are associated in emphysema is they cause destruction of the alveolar septa and distension of the alveoli. As you can see in the image, the normal alveoli have septic. But in emphysema, there are large air pockets. Air is filled in the alveoli and the alveolar septum is destructed and the alveoli become enlarged due to presence of air. So resulting in significant reduction in surface area volume for the exchange of gases. The loss of blood vessels contributes to reduced perfusion. So this is the pathology behind emphysema. Then coming to the mucus production, emphysema can also lead to increased mucus production and airway narrowing, which impairs ventilation. And there is ventilation perfusion mismatch as that seen in chronic bronchitis, but they do not typically lead to hypoxemia or acidosis as seen in bronchitis. Okay. And along with this, the important feature is there is carbon dioxide retention. Carbon dioxide retention because the surface area of surface volume is decreasing. There is no sufficient space for carbon dioxide and oxygen exchange in the lungs. Hence, the carbon dioxide get retented into the tissues because of impaired exhalation. Exhalation is impaired. Inhalation is there, but patient is not able to exhale and reduce tissue perfusion. This can lead to dyspnea or breathlessness in the patient. Okay. Then less risk of pulmonary hypertension. Emphysema has lower risk of pulmonary hypertension and core pulmonary in compared to chronic bronchitis patients. And there is mixed presentation as we have seen, as we know, mixed presentation. Okay. Then clinical features, you know, onset is middle age. So this is important. The onset for COPD is middle age and smoker's cough. Smoker's cough. So smoker's cough is like presented like patients are mostly chronic smokers only get COPD. So they present with smoker's cough before the onset of most severe symptoms. Okay, so this chronic cough is the early sign of airway irritation and inflammation due to smoking. Then gradual progressive exertional dyspnea. Exertional dyspnea is also a clinical feature of COPD. Then additional symptoms include cough. As you told, persistent cough is a common symptom which is associated with sputum production. Then wheezing. These people have high-pitched whistling sound during breathing. And recurrent respiratory infections and systemic symptoms include patients may present with weakness, unintentional weight loss, or reduced libido. So these symptoms can indicate advanced disease. Okay. Then, physical findings. What does the physician find in these people? Obstruction to the expiratory airflow. Expiratory airflow is obstructed. Hyperinflation, prolonged expiration, and pursed lip breathing. This is important. Pursed lip breathing here in this image. So, pursed lip breathing is when the patient's lips are like while breathing they keep it like this. Okay, they keep their lips like this. Okay, they because of prolonged expiration they expire even through mouth by keeping the mouth like this. Okay, so as you can see in the image here, right, pursed lip breathing. So airways, So while expiration, what happens normally is that intrathoracic pressure here decreases in the collapsed airways. But in pursed lip breathing, open airways are seen and air is expelled. Air is trapped in alveoli, but here air is expelled from alveoli. Okay, so some individuals a technique where they exhale through pursed lips to increase the pressure in the airways and improve the airflow. Then stooped posture, since they are not able to have enough oxygen, sometimes the patient sits in the stooped posture or stands in the stooped posture to increase the airflow. Then accessory muscles of respiration. The accessory muscles of respiration may also be impaired in this patient. Then coming to other findings, the bronchi or abnormal continuous low-pitched breath sounds are observed. Bronchi or abnormal continuous low-pitched breath sounds are observed. Diminished vesicular breath sounds are observed. Reduced intensity of normal breath sounds. Tachycardia, elevated heart rate. Distant heart sounds may be heard faintly. And decreased diaphragmatic excursion. Reduced movement of diaphragm that leads to flattened diaphragm appearance on the chest X-ray. Okay, then. Chest sounds may be relatively quiet in advanced stages of COPD and noisy when patients are with chronic bronchitis, which is due to excessive mucus production and airway inflammation. Quiet in advanced stages of emphysema. Okay, quiet in emphysema, advanced stages, noisy in chronic bronchitis. Okay, then cyanosis, plethoric appearance. Plethoric appearance is nothing but patient may have inflammation in the extremities or in the face or where there may be pink or red uh, lesions. Not lesions, but it appears like that. Pink, the skin appears in pink or red type of thing. Then signs of right-sided heart failure. Then patients with advanced COPD, especially those with core pulmonary, may exhibit right-sided heart failure such as peripheral edema. Okay, then physical findings, the most important physical findings which you have to remember is patient may present as either as a blue bloater, that is chronic bronchitis is dominating in this patient with COPD, or a pink puffer where emphysema is dominating. So in blue bloaters, what we see is peripheral cyanosis, productive cough, tachypnea and tachycardia. And in pink puffers, we see dyspnea, pursed lip breathing with use of accessory muscles for respiration and decreased breath sounds. Here in this image, you can see it more clearly, right? The differences between blue bloater and the difference between pink puffer. Blue bloater is experienced in a chronic bronchitis dominated COPD individual, and pink puffer is seen in a emphysema dominated individual of COPD. The symptoms associated with blue bloater are chronic productive cough, purulent symptoms, sputum, hemoptysis, and mild dyspnea initially. But tachypnea and tachycardia are the important ones. Okay. Then symptoms with pink puffer are dyspnea, minimal cough, increased minute ventilation, and tachypnea. Then signs which we see in blue bloater are cyanosis due to hypoxemia, peripheral edema due to corpuscular crackles, wheezes, prolonged expiration, and people are obese. Mostly people with blue bloaters are obese. Then signs in pink puffers, pink skin, pursed lip breathing, then accessory muscle use, cachexia, and hyperinflation or barrel chest. You can observe the chest of this patient. Barrel chest, it is important. And decreased breath sounds are absent. Then complications, secondary polycythemia vera due to hypoxemia is a complication in blue bloater. Then pulmonary hypertension due to reactive vasoconstriction from hypoxemia, and cor pulmonale from chronic pulmonary hypertension. Then complications associated with pink puffer are pneumothorax due to bulls and weight loss due to work of breathing. Okay, so this is a very important thing. You have to remember this. Okay, at least main important signs and symptoms you remember, that is enough for your exams. Then coming to the chest x-ray findings, as we know, it is normal in early stages of COPD, but as the stages advance, we can see hyperinflation. So one common finding of later stages of COPD is hyperinflation of lungs. So diaphragm is depressed, as you can see in this image. There is flattened diaphragm. Okay, then there is generalized radiolucency. The lung fields exhibit generalized radiolucency due to increased trapping of air in the alveoli. As a result, there is destruction in the lung tissue as seen in the emphysema, and hence the radiolucency is increased. The lungs appear darker. Okay, the lungs appear darker in this case. Then coming to dirty lung appearance. Dirty lung appearance is seen with patients who are having recurrent chest infections and exacerbations of COPD. Those have recurrent chest infections and exacerbations of COPD. There we see dirty lung appearance, and the appearance presents with non-specific post-inflammatory abnormalities. Sometimes it is referred to as dirty lung because increased density, scarring, or opacity in the lung fields. Okay, indicative of prior infections or inflammatory changes in the airways and lung tissue. Okay, then coming to diagnosis, the diagnosis, clinical suspicion of COPD. When can we suspect? When the patient is having chronic productive cough and there is exertional dyspnea, shortness of breath, and prolonged forced expiration, abnormal breathing pattern. If it is observed in the patient, then we can suspect for COPD. Then after this, we have to do spirometry or pulmonary function test to check for the breathing of the lungs, and RBC counts are taken, and any physiologic abnormalities are there or not, we have to check for that. Okay, then the treatment, COPD has no curative treatment. Okay, so what we have to do, if there is no curative treatment, the patient is experiencing so much of symptoms. So first thing, if there are any bronchial irritants with which he has developed it, that irritant should be stopped. So mostly smoking is should be stopped. And if there is purulent sputum associated with this cough, then it can be treated with broad spectrum antibiotics, and common antibiotics which we use are quatermexazole, tetracycline, or ampicillin for a specific duration for 10 days or like that. So this antibiotic courses may be repeated with uh, the how the symptoms are reacting towards these antibiotics. Based on that, we repeat these antibiotics. Okay, then bronchospasm. Bronchospasm can be managed with bronchodilators. So beta agonists like salbutamol and theophylline are used for bronchospasm, and facilitation of secretion drainage because of excessive production of mucus. There is should be oral fluids should be present for adequate drainage. So inhalation of mist or postural drainage and chest exercises can help to promote this. Hypoxemia management, they can be managed with oxygen therapy. Okay, then heart failure, if the patient, you suspect for a heart failure to occur in this patient, you have to administer diuretics and restrict sodium intake, and exercise should be advised, psychological support and treatment of exacerbations to be done, and phlebotomy should be done. And if there is any comorbid situation in this patient, that should also be treated. Then the question that was given in NEET MDS was, it is again a case-based scenario. So a 60-year-old male chronic smoker had dyspnea, that is breathlessness, non-productive cough, and pursed lip breathing with tightness of chest, normal wheeze. Diagnosis is. So since it is a male patient who is a geriatric patient, so we have to look for the thing which is occurring in geriatric patients. Since chronic smokers mostly they are associated with COPD only. And pursed lip breathing is another thing which they have given. That means the patient is dominating with emphysema. Emphysema is dominating in this patient, so we can go for COPD as the answer. So these remaining diseases, you have to know what are the clinical features and all for this. We are not covering that in this video, but this question is mainly based on the lung diseases. So will cover this in future videos, or and we'll then maybe you can arrive to the answer for this question more easily. Okay. Hope you like our video. So do subscribe to our YouTube channel. You can also find us on Instagram at Dogshala for dental content and at Dogshala Medical for medical content. We are also there on Telegram. We are also having a WhatsApp channel newly opened. So you can also add your friends there and discuss and share our videos and look into our preparation. Okay. Thank you.